Hi everyone, and welcome to another clinical relevance video. My name is Dr. David Griswold, and today what I want to do is talk to you a little bit about the importance of assessing neural tension and the impact that dry needling can have on it. What I'm going to do is I'm going to start with an overview looking at the neuroanatomic relationships, and then we're going to go into a case of a participant at a course that we had recently and how dry needling was able to affect their adverse neural tension. So starting with a study that was published a number of years ago, where they took individuals who had symptomatic whiplash-associated disorder compared to their asymptomatic control group. And they did a slump test as a clinical examination tool. And they found that those individuals with symptomatic whiplash were more likely to have a positive slump test. The other thing that was interesting was that these individuals, as they were putting them through the sequence of the slump, it actually produced their neck pain when they added tension through the knee, moving them into extension, and then also at the ankle as they move them into dorsiflexion. Lastly, those individuals who had symptomatic whiplash were more likely to have decreased range of motion at the knee into extension and ankle dorsiflexion mobility as well. So this study really highlighted a lot of important things, but one of those things is that the pathological changes of the neural system itself can impact adjacent tissues, affecting the mechanics of the neural system that may be a contributing factor to their actual neck pain. So let's talk about the relationship of this. So in the upper cervical spine, looking at the anatomy, you have the ability when you have neural irritation to get tension in the suboccipital muscles. And so that could be due to peripheral nerve irritation or dural irritation or central irritation as well. And so when you get tension in those suboccipital areas, it can increase tension on the C2 nerve at the myodural bridge. So the concept here is that higher level nerve irritation or nervous system irritation can create muscular guarding that can then put tension on the dural system. And we know that when you have dural restriction in one area, it can potentially lead to restrictions in adjacent areas as well. So the other area to think about that's clinically important for us as well is the thoracic spine. So we know that the thoracic spine is a highly pain-sensitive area as it relates to dural pain, as well as it can be serving as a major anchor point to the dural system as well. And so when you have chemical irritation of neural and non-neural structures, that can affect mobility in the thoracic spine as well. So our patient that we had, or participant, was an individual that had a history of cervicogenic headaches. They currently had an active headache pain level of 3 out of 10. They had a low-grade right-sided low back pain complaint that day with a longer-standing history of back pain and neural tension in their right leg, with occasional tingling into the right foot, which we see a lot with adverse neural tension problems. Now, we did an abbreviated examination and found that this individual had limited lumbar flexion range of motion. They had a positive straight leg raise on the right that was limited about 50%. And then they had a positive flexion rotation test on the right as well compared to the left side. They had some tenderness and stiffness in the thoracic region, but it wasn't actively painful. So treatment-wise, what we started with was upper cervical needling. So we needled the paravertebrals at C2, greater occipital nerve distribution, as well as some suboccipital needling as well. Now, we weren't trying to target a specific muscle. We were trying to create a lesion in order to change the chemical irritation and the sensory distribution in the upper cervical spine. By doing that, you can then alter a lot of that muscular guarding that can then take the tension off of the dura. So immediately following the upper cervical needling, the patient had some expected findings on the reassessment. Their headache decreased to 1 out of 10, and their flexion rotation test actually normalized compared to the other side. But those are things that I would expect when needling the upper cervical. What you may not expect is that she also experienced a 15-degree change in the straight leg raise and increased her lumbar flexion range of motion as well. So then we moved down into the thoracic region and we needled in that mid-thoracic zone the paravertebral points as well as some interspinous needling using just a superficial needling technique. And the goal here, again, is to be able to alter the neurochemical irritation to be able to positively influence neural and non-neural structures to help with mobility. And so following the thoracic needling, we reassessed again. And the patient's headache went to a 0 out of 10. She had no right-sided low back pain anymore. She had full lumbar flexion range of motion, and her straight leg raise was equal on the right to the left. So it's important to note that we didn't do any needling to the lumbar or to the lower extremity. We needled the upper cervical area and the midpoint of that thoracic zone as well. And by doing that, we were able to actually improve her adverse neural tension. And so this is clinically important, especially when patients are coming in with multiple areas of complaints. Are we able to establish a connection through the neural system that we can then leverage within our treatments? So I hope you found this video valuable and helpful. Hopefully we begin to look at these things a little bit deeper in clinical practice and be able to make those neuroanatomical connections. Thanks for watching.